Hi, I'm Amit Kara. I'm chair of the AHA Committee on Scientific Sessions Programming. Pleased to be with you here at ACC to recap some of the top trials. And with me is my colleague, Joe Chickwe. Joe?
Hi, I'm Jo Chickwe, Vice Chair of AHA Scientific Sessions.
Well, I know we're going to talk about some trials. And Joe, which ones I guess interested you that you wanted to review today?
Well, I'm really curious to hear your thoughts on a trial that looked at the impact of gamification in managing people's approach to their medical care.
Well, certainly the title gets your attention for sure. And as a preventive cardiologist, I really was interested in this one as well. We know lifestyle is so hard to get people to do, so I was really glad to see a well done lifestyle behavioral trial. Here they were taking individuals that had higher ASCVD risk, above 7.5%, and then this group at Penn really does some creative work using wearables and different technologies, but really randomized people to, once they found out how many steps they were doing, to usual care, or they either did gamification where they sort of would get these, as we do get on our phones usually, with some points and things, and then the other was an incentive where they would essentially get $14 every week and lose a little money if they didn't do more steps, and then the last arm was a combination of both. Interestingly, over time they saw that um, both those intervention arms did increase the number of steps significantly. And then the group that did both the gamification and the incentive had the greatest increase in step count. The control arm did as well, but all told, we're seeing about 700 steps a day. That's meaningful when it comes to cardiovascular risk. So, from my perspective, I just thought really valuable to have a well done lifestyle behavioral study. We don't see that a lot. So, pretty cool. I know there are a lot of device studies. And so, maybe you can tell us your thoughts about the Relieve trial.
Sure thing. This is a really interesting novel trial looking at interatrial shunts in the management of heart failure. And I think what's incredibly important is they actually used a placebo. So, of the 250 or so patients that were randomized, the patients that were not assigned to the treatments essentially went to the cath lab, heard a script, and couldn't tell that they hadn't had a device implanted. And I think the key findings are that the number of hospitalizations, heart failure events was actually reduced within, I think it's a 2-year follow up in patients that received the shunt rather than the placebo. However, that wasn't the case in patients with preserved ejection heart failure. So, actually, not a great option for those patients. And then the other interesting take home was that patients that got the placebo enjoyed about the same improvement in their KCCQ, quality of life, as those that got the treatment. And that really sort of, I think, asks questions about the use of quality of life questionnaires as an outcome in trials in possibly the interventional and heart failure space.
Yeah, great point. I think, it was a tough trial because obviously patients with heart failure, we need to do more for them. But, it's hard to interpret. It was an overall negative trial. But then, as you pointed out, there seemed to be a differential effect based on ejection fraction. So a lot to unpack there. And then this sort of side issue of where the KCCQ tracks as an outcome measure. But, I guess sticking with maybe pivoting, should I say, over to acute MI realm, there's a few different studies looking at acute MI and antiplatelets and things like that. I thought I'd mention that an important, I would call it a practice changing trial, Reduce MI. It's interesting when you look at sort of history of beta blockers. We've been using them for decades based on the way MIs were in the past. We'd have these large MIs, big anterior wall infarcts, and people end up having a lot of heart failure. But in the modern era, these MIs are not quite as large anymore, and with all the other medical therapies we have, where beta blockers fit in, even though they're still in our guidelines, it's great when people ask that question. Do the guidelines still, are they still accurate? So here they looked at patients that had acute MI but preserved ejection fraction on top of the usual excellent therapy, and then looking at death or recurrent MI when they randomized them to decent doses of oral beta blockers versus placebo. And probably not surprising to many, it really didn't make a difference. And it does go to say, it's not the beta blockers aren't helpful for angina or those with a depressed ejection fraction, but for all comers, just to put them on a beta blocker, maybe in the modern era, that is not as valuable as it used to be. So I'd call that practice changing, and definitely an important trial. And you and I were talking earlier about another trial that might be practice changing, the Ultimate DAP trial, about our thoughts on dual antiplatelet therapy.
I think this is really addressing whether patients that have PCI, and specifically this is in the setting of acute coronary syndrome, need dual antiplatelet therapy, which is pretty much standard of care now for 12 months. And in this multi-center trial, you've got 3,400 patients randomized to either getting ticagrelor and aspirin for 12 months or just ticagrelor. And essentially, the patients that got just ticagrelor had fewer bleeding events, adverse events, but the safety profile at 12 months was really the same. No increase in adverse events in terms of MI, need for repeat revascularization, death. So potentially, I think, and I'm interested to hear a cardiologist standpoint, something that may change practice.
Yeah, I agree with you. I mean, we really don't like DAP because of the bleeding is obvious. It was a lot lower when with single antiplatelet therapy. So that has a potential advantage. So I think, and this is not in isolation. There have been several other trials sort of moving in this direction. I will note the neat part is there's a lot more studies coming out of China, like in this trial. There's some differences in stroke risk and bleeding risk. So we'll have to sort of sort those things out and how that generalizes. But I do think it's a very important trial and maybe moving towards away from this need for automatically 12 months of DAP, which comes from a trial almost 15, 20 years ago. So possibly practice changing. Maybe extending, staying with the sort of ACS MI theme. We had Impact MI on the first day, where a big randomized trial. There's so much interest in SGLT2 inhibitors. They have value for patients we know with heart failure, with diabetes, with diabetes concomitantly cardiovascular disease. But here they're sort of asking in the MI space, again, if someone has a acute MI who may be at risk. We know that these drugs seem to lower the risk for heart failure predominantly, that these individuals that have maybe in this study, they had to have a higher risk of, had to have congestion or a higher risk of developing heart failure, EF less than 45% and other measures, randomizing sort of very early on to empagliflozin versus placebo on top of usual background therapy for an MI. It's sort of glass half full, half empty. When you look at the primary endpoint, it sort of numerically trended, but was not statistically significant. A composite endpoint, as we always have, looking at death and heart failure hospitalization. But when they kind of dug a little deeper, as expected, looking specifically at heart failure hospitalization and then even adjudicated ones, pretty significant reduction in hospitalization. And, that's pretty morbid heart failure hospitalizations, costly and morbid. They also, interestingly, these investigators had a meta-analysis updated consistent with prior data that SGLT2 inhibitors do reduce the risk of heart failure hospitalization. And so I think there's some consistent and positive findings about the ability to avoid heart failure hospitalizations with this agent. Well, I have to come back to you. Got to finish with a structural study, a very interesting one, Dedicate in TAVR and SAVR. What were your thoughts on that one?
Well, this is a trial focused on low-risk patients with aortic stenosis, and they randomized 1,400 patients to TAVR or SAVR. And it isn't the first trial in this low-risk space, but it is the first strategy trial. So any device was appropriate in the TAVR arm. And the second thing is it actually addresses one of the Achilles heels of the existing low-risk trials, insofar as only about 1% to 2% of patients had concomitant procedures in the surgical. So it's a fairly clean cohort. It's only 12-month follow-up. My take home was the disappointing observation that there was a surprisingly high risk of death or stroke in this sort of investigator cohort in the surgical arm. It's 6% all-cause mortality in the surgical arm at 12 months versus 2% for TAVR, and 5% risk of stroke versus 3% for TAVR. So it will be interesting to see how that works out in the longer term if those lines cross over at sort of the 5-year follow-up. I think it's real sort of underlines the challenges with doing non-inferiority trials. The finding is that TAVR was non-inferior to SAVR at 12 months. But again, the key is what's the 5 and 10-year follow-up for these patients.
Yeah, I think you got a great points in terms of just interesting that it's sort of more of a real world trial. Use whatever device you want. A lot of value there, and moving to a lower, younger group. But do see some from patient perspective, maybe offers people choices, but we don't know long-term follow-up, and that's going to be really important. Well, it's been a fun ACC, and we thank you all for joining us. Hopefully learning something in these clinical trials, and signing off from ACC. Thank you very much.
Thank you.